So I'm Sydne Newberry. I want to thank you for inviting me to present the results of our review. I especially want to thank Dr. Klorfeld for referring to the review process as giving birth to an elephant. That is kind of what it felt like. Second slide, please. I'm going to be talking really quickly. I'll probably skip some of the slides completely, but I understand you'll all have access to them and you'll be able to get in touch with us for further questions. Just to note, Cheryl Anderson, who's on the DRI committee, was our subject matter expert for the review, and I believe that Mei Chung has also been working with the committee, and she led the analyses of prospective cohort studies for us. Next slide, please. I especially want to thank our task order officer at AHRQ, David Niebuhr, and the partners, particularly Janet DeJesus. Thank you for your tireless efforts. We don't yet have permission to post the names of the expert panel as well as the peer reviewers, but those of you who are in the audience, you know who you are, and thank you. We're grateful for all of your input. I don't think I need to review any of the background for this topic any further for this audience, but I do need to assert that our team was not asked to assess guidelines or to set guidelines. We were asked to assess the original studies, the literature. I'm the medical editor for our Evidence-Based Practice Center. I'll shorten that to EPC, so I know that I'm never to bury the lead. And if I don't actually get to the end of this talk to present the key findings, I just want to present them up front in a very synthesized form. For these key messages, we use the terms most likely to connote that the strength of the evidence for a conclusion is moderate, not high. The term may we used to connote a low strength of evidence, and I'll talk more about that later. The evidence regarding all-cause mortality is from cohort studies, and the evidence regarding combined CVD morbidity and mortality is actually from controlled trials. So next slide, please. What are systematic reviews? So for any of you who aren't familiar with the systematic review process, systematic reviews have basically two defining features. Their aim is to identify and synthesize all evidence that pertains to a question of interest, and they use a fairly standardized and completely transparent set of methods, meaning that you should be able to repeat the review that we did by reading our instructions. I just want to note a few things. Next slide, please. So I'm on slide 7, evidence review process for this report. Just to note a few things about this particular review. The statement of work that we received actually defined the questions as well as a number of the inclusion and exclusion criteria. We set out to search for both original studies as well as existing systematic reviews as an additional source of studies. So we, quote, reference mined systematic reviews in case we missed anything. The protocol is actually published online and is registered with Prospero. Next slide, please. So we always start a review with an analytic framework to define the proposed relationships of interest. We were interested in assessing both intermediate outcomes, that is blood pressure change, and longer-term outcomes, so cardiovascular disease, morbidity, and mortality. So this is the framework for sodium. Next slide, please. And you should see the analytic framework for potassium. Potassium had an additional outcome, which was incidence of kidney stones or recurrence of kidney stones. Next slide, please. So I will quickly go through the key questions that drove this review. Next slide. For each set of outcomes of interest, questions were divided into those seeking trial evidence. So those are the odd-numbered questions, 1, 3, 5, and 7, and as well as evidence from prospective cohort studies, which are the even-numbered questions. We were also asked to assess the potential moderating effects of a specific set of factors that are shown in the sub-questions. So, for example, A, B, and C. lists the potential moderating factors of interest. So the first two questions related to sodium and blood pressure, trials and cohort studies. Next slide, please. Questions 3 and 4 related to sodium and the longer-term outcomes. Next slide. Questions 5 and 6 related to potassium and the shorter-term outcomes, so the blood pressure outcomes, risk for hypertension, as well as risk for kidney stones. Next slide, please. So questions 7 and 8 related to potassium and the link to the longer-term outcomes. And those were the key questions, and I realized I went through them incredibly quickly. So basically, the first half of the questions were devoted to sodium. The last were devoted to potassium. So if we can go to the next slide on literature searches, this is a list of the sources that we searched, in addition to doing hand searching of some gray literature, and as I mentioned, reference mining of prior reviews. And we also took into consideration expert recommendations for additional studies. The search dates nominally were 2003, so the year before the prior DRI review, to 2017. However, because of reference mining and additional suggestions, we went well back into the early 1980s. Next slide, please. I want to just very briefly go through some of the key inclusion and exclusion criteria. If you actually refer to the full report, those criteria go on for pages and pages. They were actually question-specific and study design-specific. So I'll just very briefly go through a few that were kind of high on the list. For example, we excluded cohort studies from certain analyses of participants already had the condition of interest. Just to relate it to trials, it would be like looking at risk for hypertension in a population that already had hypertension. So that was the reason we excluded those. We excluded multi-component trials if they didn't allow the effect of sodium to be assessed in isolation. We excluded studies that infused sodium or potassium, so we only looked at oral intakes. And I'll say more about assessment of intake in a minute or two. So if you go to the next slide, inclusion-exclusion criteria 2, the outcomes of interest were pre-specified in the statement of work, as were the methods of assessment. Timing was also pre-specified in the statement of work. In other words, the duration and follow-up times, the minimum duration and follow-up times. As you can see, some of them were fairly long. For example, more than 2 years for renal disease outcomes, more than 3 months for trials of CVD outcomes, and actually 12 months for prospective cohort studies or follow-up. We included almost all settings except inpatient hospital settings for probably obvious reasons. We excluded all observational studies except prospective cohort studies, and we included pretty much any controlled trials. We did not include single-arm trials, in other words, uncontrolled trials. Next slide, please. I know there's a great deal of interest in how sodium intake was assessed. We have very stringent criteria that we actually made more and more stringent as we started to go through the literature. This slide just, the risk of bias for exposure slide briefly summarizes the criteria we used for RCTs. I don't want to take a lot of time to address how we assessed study quality in relation to intake methodology, but basically for trials, we accepted studies that used 1 24-hour urinary sodium excretion with validation, because for most trials, sodium intake was being assessed through urinary excretion to assess compliance with the study intervention. There were much stricter requirements for observational studies. If you go to the next slide, risk bias for cohort studies. For cohort studies assessing sodium, we required multiple 24-hour urinary sodium excretion with validation for a low risk of bias. In other words, a low quality, a high quality assessment of that study. And with the exception of studies that used food frequency questionnaires, we didn't exclude any studies because of the method that was used to assess sodium. We simply rated the quality of the study based on largely on the method that was used. And we didn't take any high risk of bias or low quality studies into account when we drew conclusions based on the observational studies. If you go to the next slide, risk of bias for potassium exposure, we did consider multiple food records a recall for potassium, largely because of the lack of clarity about urine excretion of potassium as being a valid indicator of potassium intake. Just one more thing I wanted to mention about risk of bias or quality. I didn't put up a slide that lists the tools that we actually use to assess quality. We use standard tools to assess risk of bias or study quality for both RCTs and cohort studies. And there were minor modifications, namely we added some criteria for nutritional studies. And those tools are actually reported in one of the appendices to the report. If we go to the next slide, assessing the strength of evidence, I'll briefly mention our actual data syntheses when I present the results. However, after synthesizing the data, the actual conclusions and the strength of evidence supporting the conclusions were determined using a modification of the grade method. I know some of you are familiar with that, which takes into consideration 5 domains. So study limitations is basically the quality of the studies, the numbers of the studies, the size of the studies. Directness depends on the types of studies we're looking at. So in other words, intra-study comparisons of subgroups versus inter-study comparisons. Consistency, we considered consistency only with regard to similarity of effect directions across studies. And then precision is basically the size of confidence intervals, and reporting bias, the extent to which we believe that studies actually reported what they said they were going to investigate. So next slide, please. The definitions of the levels of strength of evidence, I'm certainly not going to read these. This slide shows the actual grades that we use. For trials, we would start with a grade of high, and then we would demote the grade 1 unit each for each poor domain rating. For observational studies, we tend to do the opposite. We tend to start with an insufficient or a low and then build it up for factors that are in the favor of those studies. So I'd like to now go on to the results. So if you want to skip over 2 slides to the flow diagram, I realize this diagram is probably pretty impossible to read. This is actually the record of the numbers of publication titles that were identified and screened, and then the number of articles that were full text searched and then abstracted. Both the lists of included studies and the list of excluded studies, at least excluded at full text level, are in appendices, as well as the reference list, and the appendix lists the reasons for exclusion. And I realize I'm probably going way over. If you go to the next slide, this slide shows a typical forest plot. This plot is for systolic blood pressure and sodium. Just very, very quickly, I want to point you to the list of included studies on the left-hand side. The study heterogeneity is at the very bottom of that list. The effect sizes for each study are listed along the right-hand side in that column. The sizes of the points on the actual graph correspond to the trial sizes, and the actual pooled effect size is at the very bottom right. So to go on to the next slide, the next 8 or so slides, so I'm on key question 1, the key findings. So the next 8 or so slides summarize the key conclusions that had at least low strength of evidence. I'm definitely not going to go through all of them. I'll just note that we didn't assign a high strength of evidence to any of the conclusions, mainly because of inconsistency across study findings. So a moderate strength of evidence supports an effective sodium reduction on blood pressure across all adult studies, and the effect was greater in studies of adults with hypertension than in studies of adults with normal blood pressure. And we did not see statistically significant effects in children. However, the number of studies of children was very small. Realizing that my time is really disappearing, I'll just note, if we go to the next slide, key question 1, sodium 2, we saw similar findings for the use of salt substitutes. Next slide for key question 2. I should mention that our conclusions based on cohort studies were completely separate from our conclusions based on trials, and they were all low strength of evidence or insufficient evidence, primarily due to the sodium assessment methods. So key question 3 were the long-term outcomes. As I think we all know at this point, there are very few trials assessing the longer-term outcomes, and they were all low strength of evidence, partly because of the numbers of trials, partly because many of the studies only assess these outcomes indirectly as adverse effects. They were not pre-designed to assess these outcomes for the most part, and we actually found no studies that looked at renal disease as an outcome. If we go to the slide for key question 4, the major take-home from this, from the cohort studies on longer-term outcomes for sodium, is that among cohort studies, sodium intake appears to be associated with risk for all-cause mortality, but the study quality was mostly poor, and we did not find sufficient evidence to support any other associations for sodium. I will actually skip over the findings for potassium, except to mention that for potassium trials, we did find an effect of potassium supplementation, not from food studies, but from supplement studies on decreasing blood pressure in adults with hypertension. If we go to key question 6 slide, I believe it was mentioned that there are actually 4 prospective cohorts that have looked at the effect of potassium, or not the effect, the association of potassium intake with kidney stones, and there does appear to be an association of higher potassium intake with lower risk for kidney stones. We actually found no studies, or one marginal study that addressed the effect of potassium on the longer-term outcomes, so we could not draw any conclusions. And for the final key question, which looked at cohort studies and potassium and the longer-term outcomes, most of the studies had a high risk of bias, and the evidence was considered insufficient. So to go to the overall conclusion slide, I think you probably have somewhat of an idea by now of what our conclusions were. I don't think I need to go into that. To go to the limitations slide, we tried to be pretty specific about what we thought that the gaps were in the literature. I think that Dr. Apple probably has already identified a number of them. Basically, there were a few within study comparisons. We found that many of the studies failed to control for use of antihypertensives in hypertensive populations. There was difficulty in really knowing the baseline health status in cohort studies. The variation in trial designs made it difficult to really compare or pool studies. Although we pooled them, there was high heterogeneity. In other words, differences across studies. And of course, for the cohort studies, we know that most did not assess sodium intake adequately. To go to the limitations of the literature 2 slide, we also noted that the method for blood pressure measurement tended to diverge quite a bit, particularly among the older studies, and that was a concern. And finally, to go to the limitations of our review, which is basically my final slide, partly due to time constraints, there was a very large number of studies that we were trying to consider. We did some sensitivity analyses. We excluded studies that had poor quality. However, we did not do any sensitivity analyses eliminating studies that didn't control for medications, and we didn't consider blood pressure measurement in our analyses. So I think that's probably the end of what I want to say, and I'll be happy to take questions. Thank you very much.